Uh, I'm Dr. Nishant Rajkakoti. I'm a radiologist. I'm from Dr. Das Multi-Specialty Hospital located in North Lakhimpur, Assam. My case is a lady aged around 29 years. She came for obstetrics ultrasonography at around 14 weeks, 5 days gestation. It was a natural pregnancy and previous scan reports were not available at that time. But she gives a very bad obstetric history of 2 earlier miscarriages. When we started the scan, on the very first sweep, we could see some striking feature. There are multiple cystic spaces which are non-communicating located in the lower part of the abdomen. And these were the enlarged kidneys with multiple cysts. The parenchyma was replaced by multiple cysts. When we saw the axial view, we could see that yes, both the kidneys are affected. So it is a bilateral condition and the bladder was not visualized during this scan and the amniotic fluid was adequate amount. On careful search, we could see one more striking finding and that was a occipital encephalocele. So it prompted us for more evaluation and on careful search, we could see one more anomaly and that was a post-axial polydactyly. So in this case, we found 3 major findings. So when these 3 findings are present together in one case, we can conclude or we can establish a diagnosis on imaging alone, and that's the diagnosis of Meckel Gruber Syndrome. It is said that in Meckel Gruber, the dysplastic kidneys are present in 100% of the cases, the occipital encephalocele present in 90% of the cases, and polydactyly in 70 to 80% cases. So based on imaging alone, we could establish this diagnosis. What is Meckel Gruber syndrome? It's a autosomal recessive, lethal, multi-system disorder. A mutation in multiple genes have been documented, and its incidence is 1 in 135,000 worldwide. But it is higher. It is seen in higher in endogamous population, like some Gujarati Indians, some countries like Finland, where the ratio is as high as 1 in 9,000. It is more higher in consanguineous population, like the Kuwaiti Bedouin tribes, some places of Saudi Arabia, and few other countries where ratio is as high as 1 in 3,500. This is a type of ciliopathy, and it's a multi-system disorder. Hence, variable phenotype is seen. How do we diagnose? If multicystic dysplastic kidneys are present with at least one other typical feature, like the occipital encephalocele, hepatic fibrosis, and or post-axial polydactyly, then we can conclude this diagnosis. Hepatic fibrosis is a histological diagnosis, but the other 3 features, if these are present, so based on imaging alone, we can establish this diagnosis. But if we want to go for a confirmatory diagnosis, then we have to go for genetic testing and maybe autopsy as well. So, counseling plays a very important part in this condition. How it helps? It helps during the diagnosis, because diagnosis can be established by ultrasound as early as 12 weeks if all the 3 classical triads is present. So if the classical triad is not present or if some overlapping features are present, then we have to go for invasive testing, maybe CVS, and further go for genetic testing. It's a lethal condition. So either the fetus will die in utero or soon after delivery. So counseling plays a very important part. One is for diagnosis, that ultrasound alone can establish a diagnosis, or maybe genetic testing may be required for confirmatory testing, and it's a lethal. So we have to offer them earlier, safer methods of pregnancy termination. Some couples may not want to go for termination, so then we have to refer them for pediatric subspecialties. Counseling also helps in genetic testing, because genetic testing can confirm the diagnosis, and it also helps in genetic counseling. There are various strategies for genetic testing. If we know the genes which are affected, like if previously babies were affected in their parents, then we can go for individual genes mutation screening or multi-gene panels. But if we don't know the genes, or if these reports comes inconclusive, then we have to go for further comprehensive tests like the whole genome or whole exome sequencing. Counseling also plays a part in the discussion of risk, because it's an autosomal recessive disorder. There is a high chance that the next pregnancy will also have the affected baby. It's 25% recurrence chances. So the couples with a previously affected child should have the opportunity for genetic counseling to discuss the nature, the inheritance, and the implications of a MGS diagnosis. It also helps in carrier testing. If the couples both are carriers, then the baby will be affected. But we can have a healthy baby by the help of donors. This is a very new coming topic. It's gaining popularity, gaining acceptance also in the society. This is just a bypass or an alternate way to get a healthy baby for at-risk couples. So it is therefore appropriate to discuss these issues at a very early stage to ensure families can make informed medical and personal discussion. So what is the most commonly missed anomaly? If I may ask, the answer is usually the second anomaly. So this should be a take-home message. Like if we get one anomaly, then it should prompt us to search for the second anomaly, or maybe a third, maybe fourth. So it helps us in solving many complex syndromes, because syndromes usually present with multiple findings. Before I conclude my presentation, I would just like to share a few of my fond memories. This was a picture taken in 2020 with Dr. Professor Khurana sir. It was the first inaugural CME of SFM in Guwahati. And I have one more picture with Dr. Mohit sir in 2022. I got the opportunity to meet them first time in Guwahati during this CMS, and today is a very remarkable day for me. Both the mentors are present here, and today I'm presenting one case in front of them. And for all this, my guidance, I would like to thank Dr. Jeena ma'am for giving me the opportunity and all the guidance. Since the time I have started my journey in fetal medicine, Jeena ma'am has always been there. And with this, I would like to thank the mentors for visiting this part of the country. I would like to thank the organizers and all the delegates for a patient listening. Thank you, everyone.
Thank you, Dr. Nishant. Sir, any comment?
So we have here, where we have a definite phenotype. Thank you. So we have a definite phenotype.
Yes, sir.
And therefore we have a genotype. So why should I do any genetic testing at all?
Now for this case, sir, that classical tried if it is present, and we
Yes.
can establish by imaging alone.
Excellent.
If the pictures are overlapping or if the classical triad is not present, then we
Yes.
can go for further genetic testing to differentiate other conditions.
Absolutely true. And we need to differentiate it from other ciliopathies.
Yes, sir.
And then we will do the carrier screening, and we will help them to plan the next pregnancy.
Yeah. So
Whether
next,
they can have their own baby
yes,
or
or
they
maybe
cannot. Yes.
maybe a donor,
Yeah.
maybe.
Absolutely correct. So we still do need genetic testing. The
Yes.
second thing is that when we do a group of genes, we do single sequencing, which is much cheaper than
Yes.
exome sequencing.
Yes, yes.
So
Cost.
that's right. So my first one is known. I know the genes. I know them from whole exome. I've confirmed it with single sequencing. In the next time, if I have any vague finding or no finding, and I want to be sure that nothing will happen in the future, then in my CVS, I will make sure that I do single sequencing at a much cheaper cost
Yes.
than otherwise.
Yes.
Excellent. Yeah. Very well done. Beautifully presented. Beautiful case.
Thank you, sir. Thank you so much.
Nishant? Thank you, sir.
Thank you, Lee.
Thank you, everybody.